Okay, so at 22 weeks, you have the complete invasion of the trophoblasts by spiral arteries into the uterus. You will hear about these spiral arteries all the time. So be sure that you know what they are and what they do. It's basically little corkscrew arteries that travel from the placenta into the uterus, and that's where blood and gas exchange happens. There are thoughts on many complications of pregnancy that are actually related to these spiral arteries, in addition to all of the placental hormones. Um, so, obviously, like we talked about a minute ago, as the placenta gets bigger, the baby gets bigger, you need more blood flow, you need more oxygen and nutrients. So, there's a decrease in maternal blood pressure in the second trimester. So, if you're seeing a woman who had normal blood pressure in the first part of pregnancy, and now you're seeing a trend upward in blood pressure in the second trimester, you don't love that. So, because it should be at its lowest. We will talk about hypertensive disorders of pregnancy, but just know that it's all related to the placenta. So here are a couple of great pictures. This is the placenta. I would find this online and really look at it because you can see those spiral arteries and the gas exchange that happens within the placenta and the uterus. And of course, we have a sweet little baby in here, and the placenta. See how the placenta is attached in the top third, so near the fundus of the uterus. That's the perfect textbook place. And this is what the umbilical cord looks like. It should be nice and I call it juicy. It should be nice and thick. You have one vein and two arteries. So you have to remember that these are the opposite of what maternal veins and arteries are, because it's related to the difference in blood flow. So in the umbilical cord, the vein is what is actually sending blood and nutrients in. The arteries are what carry it away. So it's the opposite of maternal, right? Our arteries send out blood and oxygen to our body, and the veins return them. And that is different in the umbilical cord. So we're going to talk about some abnormal placental placements. And the reason I'm putting it here is that you typically you're going to find this, like I said a little bit ago, in that anatomy scan. So these are variations of placement, right? So placenta previa is the one that you will see most often, and it can occur in lots of different degrees. So this is the complete or total placenta previa. Complete is the term that you will hear used. So you can see that there is placenta on every surface of the cervix. So it's completely covering it. You will have a partial placenta previa where, just like it says, part of the placenta is covering the opening of the cervix, right? So it's not covering it, but it is over the edge of the opening there. Then there is a marginal placenta previa, which means it's not going out into the cervical opening, but it is right on the margin there. Low lying is here, which means it is in the lower third, typically, of the uterus. So, like I showed you in the picture before, the placenta typically attaches up here, the most normal placenta placement. If you go back to embryology and how things are formed and developed, where they come from that tube, that's why the most likely placement is typically in the upper third of the uterus near the fundus. So about 4 to 6% of patients have some degree of placenta previa. Now, marginal and low lying, we are not calling previa, and there are a couple reasons. But this, again, is not normally diagnosed at the anatomy scan. So what we will tell ladies, sometimes in this partial, depending on how much is covering that opening, for sure marginal and low lying, low lying is the most likely for this to happen, is it will move. Now, I think we talked about this class. It does not get up like a little crab and walk to a different spot, right? During pregnancy, this lower uterine segment here is very, very thick. And so as the uterus, see how long that is, as the uterus grows and stretches, the placenta where it is attached grows with it. So it doesn't move, but as the muscle grows and stretches, it goes along with it. So sometimes the partial will get better, rarely. Sometimes a marginal will get better, often a low lying will get better. So, like it says there, 90% of those in the lower uterine segment will resolve by the third trimester. Complete is the least likely to resolve. I have never seen that happen, but it says only 10 cases resolving by the third trimester. My thought is that it probably wasn't an actual total placenta previa when it was called that, if it resolves. But either way, that's what the literature says. Then there are variations of what is called placenta accreta. And this is, again, in varying degrees. And if you see those pictures there. So this is where there's abnormal attachment. So not abnormal placement, but abnormal attachment of the placenta that is actually going into it's an abnormal myometrial attachment, right? So those placental villi are growing down into the deeper layers of the muscle of the uterus. So a superficial, so here's normal, right? The most superficial of these is the accreta, which means the placenta itself is growing down into the superficial layer of the uterus. A little bit deeper into that muscle layer is called an encreta, so you can see here. And then a percreta is where it can go all the way through the muscle, not through, but all the way through the layers of the muscle. So why does this happen? That's a good question. The most common reason it happens is women with a prior uterine surgery, right? So maybe more than one D&C, a C-section, fibroid removal, any type of surgery, because now you have scar tissue on the inside of the uterus and the placenta attaches there, which it's most likely to, right? Because there's something a little extra to grab onto. Then it can grow into this. Most of these are delivered by C-section. A percreta is almost always, it ends up as a hysterectomy because you can see that you can't remove the placenta without the uterine wall. So sometimes with the accreta, they can go in and remove part of this muscle. Increta sometimes, but when that is extending into the uterine serosa, remember that's that very outer layer. So when it's all the way there, if that if you tried to remove that, it will be devastating. So these are ladies that they would be delivered by C-section, because you have to be sure that you have removed all of that placenta. But yes, if they have a percreta and or they don't plan on having any more children, they just do deliver a baby and have a hysterectomy. Another thing to think about at that point is think about all of this blood flow that is going to the uterus, right? Even though you've just removed the baby, there is still a significant amount of blood flow to the uterus, and now the body's sending blood to repair itself. So this is a very, very high risk hysterectomy as well. So a lot of these are done, even in big hospitals, are done in the main operating room, not on labor and delivery, so that you have urgent care available. And so this is another visual. I think it's a really good visual of what these abnormal placentations are. So see, the placenta normally is attached to the endometrium. And then the accreta, it's in the myometrium. Increta, it's deeper in there. And the percreta, it is down in the serosa of the uterus. Then you can have abnormal umbilical cord insertion. So now we're talking about abnormal cord insertion into the placenta, okay? So you can have, let me see if there are pictures on the next page. Yes. There's marginal cord insertion, which means that the cord is attached to the margin or the edges of the placenta instead of the center. And the way I explain that to patients is that, the placenta is, if you laid it down, it looks like a little, like the top of an ice cream, right? So it has that circular portion that's fat on top and thin on the edges. So that's why the normal placement of the umbilical cord is right there, pretty much in the center, because that's where you have the majority of exchange going on right there. So it's actually fairly common. We don't know why it happens, but it does. It typically doesn't cause any problems. However, if the edge of that placenta starts to come up, or come detached, which is not good anyway, but you're going to have a faster you're going to have a faster problem with mom and baby because that umbilical cord is pumping. The velamentous is when the cord inserts into the fetal membranes, like the chorion of the placenta. So if you've ever seen a real placenta, and I think I have a picture in here too, there are the chorion is that part of the amniotic sac, which covers the placenta. So you have a maternal side and a fetal side. The fetal side is covered with this chorion, so part of the amniotic bag. So the placenta has the amniotic sac on one side and the attachment to mom on the other. So that's why there's only this thin membrane on the inside, or the internal fetal side of the placenta. Sorry. So the cord inserts into that chorion instead of right down into the placenta. So Again, seen on ultrasound, this is also, I don't know the percentage of time. It's uncommon, but I've seen it a lot. Now these are more at risk because the vessels are not deep inserted into that tissue of the placenta. They are much more loose and can get twisted more easily, things like that. So those are women who are going to need additional surveillance in pregnancy. And then avasa previa, which is very rare. Um, Again, you have that previa word, so that can get confusing. So the previa part of it is that the blood vessels will run across the opening of the cervix or between the baby's head and the cervix. So some sort of abnormal positioning of the blood vessels and placenta or membranes. So you're going to see it on ultrasound. You're going to see it more often in a velamentous cord insertion or a placenta previa in general. It's rare. I've only seen one patient with this. So, yes, they get a C section. So, here's an image of the normal cord insertion you can see in that middle part of the disc of the placenta. And then marginal is where it is implanted out here. So it comes from the side or the margin. This is pretty cute. So this is all umbilical cord, and see how the vessels are actually inside the placenta. This is the velamentous, where you can actually see those vessels are not attached all the way inside the placental site. They are inside the placenta itself. See how they're in that chorion. They're inside that amniotic sac. And this is avasa previa. So these are actually fetal blood fetal blood vessels that are not necessarily within the umbilical cord. And they are presenting prior to the baby, right? So they're previa. A normal umbilical cord has three vessels. And so you can have a single umbilical artery instead of two arteries in one vein. You can have just one artery, which gives you only two vessels. That was super clear. The typically, it's pretty uncommon, and you can see it on ultrasound. Most often there's not an issue, but again, this is someone that you do increased surveillance or screening on her. So again, like I said earlier, maternal adaptations to pregnancy. Pregnancy is a physiologic state, not a pathologic state. So most of the things that we are seeing are normal, and the effects that happen to mom are because of the normal changes of pregnancy, growing a human, making blood, getting rid of waste products. So again, these are some more maternal adaptations on this table. I am not going to read all these to you, I promise. Changes in the immune system. The way I word it to moms is I say that their immune system is suppressed so it doesn't fight against the baby. That's not really true. The immune system is not suppressed, but it's a quality difference in the immune response. So the placenta there is semi-allogenic, so semi-allogenic, which means it's half mom, half baby. So there are fetal cells there. The cells are half mom, half dad. So those are the fetal cells. We do believe that vitamin D plays a pretty strong role in the immune system. A lot of, that's my dog barking again. Some practices will check vitamin D in a pregnancy. Certainly, moms who we already know have a low vitamin D level need to be monitored during pregnancy and medicated with the prescription vitamin D. Sorry, he's old. He goes to the other room and gets lost. Okay, vitamin D. These are all the changes that happen in maternal cardiovascular system. So that cardiac output has to increase significantly because of all of the blood flow to the placenta, the mom's increased blood volume. This is why you can hear a functional murmur in moms. That's very normal. That heart gets displaced due to everything else pushing up. It takes about 6 weeks postpartum for the cardiovascular system to return to normal. So again, those hematological changes, the white blood cell count is going to be elevated a little bit, and that is normal. They do have moms have a higher iron requirement in the second trimester because of the dilution of the blood volume. Also, the fetus and placenta require 300 milligrams of iron a day, and because we're making more maternal red blood cells, we need iron, and then we are excreting about 200. So those are the ones, that's why you're looking at their CBC and seeing if they need extra iron. These are kidney or renal changes during pregnancy. Because you have all this extra blood flow, then you have increased renal plasma flow, right? So your BUN and creatinine are decreased. You have dilation of the ureters because of, you've got the uterus typically grows up and displaces to the right just a little bit. So you've got, and then the decreased smooth muscle contractility. So it's more typically on the right side because of that uterine displacement. Can actually cause hydronephrosis. It's one of the reasons that pregnant moms are more likely to get renal calculi or pyelonephritis tends to be more often on the right side. Hydronephrosis is more common there. So there's more stasis of the urinary tract right there. So maternal position change can actually change what the kidneys are doing. So in the lateral position, you have plenty of flow you have plenty of room, and nothing is impeding the flow through the ureters. So we think that's one of the reasons that moms have to urinate more often at night during pregnancy, even if you tell them to stop drinking fluids at a certain time, those types of things. So when they lay on their side, all of that, you've got gravity is relieved and the displacement is decreased. So obviously you have respiratory changes because we need more oxygen. Because of the progesterone increases, it signals the brain to lower carbon dioxide. So it increases the respiratory rate, changing the plasma pH. The uterus interferes with the expansion of the lungs because it will press up on the diaphragm. The thoracic circumference actually increases by about 10 centimeters. Increased oxygen consumption. There it is about the nose and the nasopharyngeal obstruction, mild dyspnea. So this is why moms will have, obviously, this is why they have an increased respiratory rate. Um, this all happens because the lungs need more room for oxygen. You've got an increased burning of oxygen. You're using more to grow for the other human that's there. Moms will complain of congestion, stuffiness, stuffy ears, stuffy nose. That's why, is because of this obstruction of the tubes. This is why moms feel like they need to take really deep breaths because they are trying to force that diaphragm down so they have more room for the lungs to expand. Okay, we'll take a break.